Hi, good day to you all. My name is David. I'll be speaking today about chemotherapy-induced peripheral neuropathy uh, and using YNSA in treating this disorder. So first of all, I'd like to thank Ricardo Filho for inviting me to speak at this Congress. First time I've been invited to speak in a Congress in Brazil. I think sometimes online actually open kind of doors for new acquaintances, new places to speak. So I'm greatly honored for you inviting me to give a speech and a lecture and a talk. So this lecture will be in English. Hopefully you'll have some kind of translation to Portuguese. Whoever's not familiar with me a lot, I've been practicing I'm a Chinese medicine practitioner who specializes in neurorehabilitation with the use of YNSA. I also teach this method around the world, and I've been teaching and guiding also students in my clinic. In my work, I have a clinic in Israel, in Haifa, where YNSA is being practiced, where we see many types of disease, also for internal problems. And I also work at a hospital in a rehabilitation department, where for the last 10 years, where there I'm going with clinical research, how YNSA affects patients in rehabilitation, how it does it, how it makes their recovery a lot quicker and a lot faster. In my work, I often stumble on to patients that suffer from neuropathy. Could be different reasons and causes for neuropathy, but one of the things, a lot of them are patients that are recovering from chemotherapy, and now they have this peripheral pain, neuropathy, which was caused from the chemotherapy. And actually using YNSA is a great instrument in treating these patients. And this is our talk today. So I'm going to share my screen. So how to treat chemotherapy induced with peripheral neuropathy, which is also known as CIPN, with YNSA. I like to always say this is the most important page, I think, in my talk, because this is our contact information, not our contact information for marketing, but more for contact information if you have any questions that come up during this talk. Because this talk is not live, so it's not, I cannot receive any questions lively, so you have my contact information where you can also send me a message and an email asking a question regarding a certain patient, and hopefully I can assist you in you. So you have our website, you have our email page, you have our WhatsApp. We use WhatsApp, so you can use the WhatsApp. Why I'm saying we, because also me and also my business partner Avi will answer you if necessary. And you have our Facebook group, where there you can just ask questions, and not only we will answer, but other practitioners around the globe who also have experience with this method, and maybe even better tips than what I use, because they see different care in different patients. So, what is peripheral neuropathy? First of all, before we speak about peripheral neuropathy, just to touch base, we have to speak about the nerve system. So the nerve system is broken down into two major systems. One of the systems is the central nerve system. So the central nerve system is actually the cerebrum, cerebellum, brainstem, all what is in from the area of the brain downwards to the spinal cord. That is the central nerve system. The peripheral nerve system is all the nerves that are out of the spinal cord and beyond the spinal cord and beyond the brain. Okay, that's peripheral when we speak about peripheral. and how the nerve system works. We accumulate through the peripheral nerve system. I get sensory stimuli that goes through the peripheral nerve system, goes into the spinal cord, goes up to my brain, to the central nerve system. Once it's in the spinal cord, in the central nerve system, I analyze this information. I analyze it through, when I receive this information, through past memories to new memories, and then the information goes down through the central nerve system towards the peripheral nerve system and causes a motor function. Okay, now motor function could be anything. Motor in movement, but also secretion of saliva is a motor function. Movement of my bowels could be a motor function. Okay, anything that throughout that could be a motor stimuli. Okay, neuro is related to nerves, so when we know we have neuro, we know the problem is going to be related to the nerve system. And pathy is disease, just to understand what peripheral neuropathy means. So with that, we can move on to the lecture itself. First of all, so we have nociceptor or neuropathic pain. What are the difference between the two? So first of all, nociceptors are receptors that perceive information of pain. Okay, they have three endings in a certain area. They can be in a muscle. When I'm receiving information that I have some inflammation in the area of the muscle, or I've been hit in my hand, the nociceptors start perceiving this information, okay, and send this information that goes right up towards, goes through the dorsal root of the spinal cord, and it goes up towards the brain itself, goes through the thalamus, and then the thalamus interprets this pain and then responds to this pain. Okay. At the same time, information goes down from my brain towards the area of the spinal cord to modulate this pain. So to make sure that the information of the pain is modulated and it's not giving too much or too less, and then it goes modulates the pain goes up to the thalamus, and then I perceive that information that there's pain or I'm suffering from some type of pain, and there's a cause of it, and I can respond to this cause. Maybe I'll develop inflammation in the area to kill the tissue that's been damaged, or I'll pull my hand away because I've been feeling pain because I touched a thorn or someone hit me, so, and etc. But that's nociceptic pain. Now, neuropathic pain is any damage that can be caused to the nerve throughout the pain pathway. Okay, that means there's some type of damage, could be chemical, could be even pressure on a certain area. When the pressure with time is caused a signal that the pain is not modulated and it keeps being sent towards the thalamus, and then the thalamus starts perceiving it and sending out the signal of pain. And there could be no inflammation in the area that is causing this pain, and there's no modulation of this pain. And I just keep receiving this input of pain, and there's no cause of this pain. And that's basically the idea of neuropathic pain. And it could be occurring throughout, could be occurring in three endings, nerve endings, in the area where the nociceptors are there. It could be in the spinal cord prolapse disc, for example, that's causing pressure on the nerve there, and it keeps sending out the signal of pain, and then there's some information that is kind of misinterpreted throughout the body, and I keep receiving that pain. I like to look at it as if the brain is a map, for example, okay, if we have our brain is like a map or a picture, we see everything as a picture, and the nerve is also some type of picture. It's kind of the area, and that information, that picture is kind of blurry. So if that picture is blurry and I can't see it correctly or can't see it well, it's going to send out blurry information up towards my brain. And then my brain is going to perceive it, that information in the incorrect way. And then incorrect way, and that's going to be the response. And the thalamus is responding and causing pain. A good example for that is, for example, if my hand is being amputation or phantom pain. So if I have an amputation, my hand does no longer exist, for example, but actually the map is kind of blurry of the hand, and the hand still exists somehow, and it's sending up information towards the brain, towards the thalamus, and the thalamus is always innovating or receiving this sensory stimuli and actually causing saying, okay, your hand is sore, the hand is being amputated, and you're getting this or this itchy feeling because the image is actually very, very blurry. So you have to kind of in some way cause the image to be less blurry, and then you're going to get the precise information. So there's all these techniques like this mirror therapy with mirror therapy, which actually tricks the brain in some way and shows it a different picture, but then actually it starts perceiving this information, and then the information will suddenly the picture or the map becomes a lot more clearer. So the information that's being passed on towards the brain is a lot clearer, and then the brain say, okay, there's no hand there. Why should I keep receiving pain? Or why should I have this itching feeling? Why should I have this pressure feeling? Okay, or pins and needles, for example. Okay, so you want to actually in some way regenerate the nerve somehow, because the nerve has, if the soma is not being damaged, the nerve can regenerate, and the nerve can regenerate about a millimeter a day. So throughout a period of time, you can actually get the sensory stimulation in a better contact, or the nerve will be functioning a lot better, the sensory nerve. So symptoms that can be occurring when we have neuropathic pain, we have could be a stabbing feeling, could be a burning feeling, could be electric shock feeling, could be stinging, itch, tingling, pins and needles, tightness. Okay, all this sensory of pain could be interpreted into pain. Okay, numbness. Okay, balance. Okay, why do I mean numbness and balance? If, for example, you're not feeling a certain area of your body, that's going to affect the proprioception. Or if you're having a problem in numbness in the area of your foot, for example, in peripheral damage to your foot, when you start walking, you can actually feel that you're unbalanced when you walk, because actually the information, the sensory stimuli there is incorrect. Well, again, the picture, the map is blurry. So the information is not going towards the brain. Pins and needles, of course, and you have a dead feeling. Dead feeling means you have feeling that doesn't exist there, right? You can have muscle involvement, which could be tardiness, okay? The muscles might feel very, very tired, fatigue. You could have foot drop, could be also a neuropathic disorder. And then you have temperature, which could be hot or cold. Okay, all these symptoms can be occurring when you have neuropathic pain. And think about patients. If you've stumbled into patients or when patients come to your clinic and they have had chemotherapy, or you can see that a lot of their complaints could be not only I have pain, okay, I might have pins and needles, I might have these electric shocks at every now and then. Okay. Now, what I want to say that there's a difference between neuropathic pain can be peripheral, and then we know that it's damage or some kind of damage to the peripheral nerve system, or it could be central nerve system damage. And then, for example, like a patient with a stroke who's suffering now from neuropathy, that we know it's central nerve system damage. Okay, and then it's kind of the area in the brain picture is become blurry, and the information is not perceived correctly. Okay, with the peripheral, it's just the nerve, the peripheral nerve that's damaged, and the pathway is also kind of clogged in some way, to say. So causes of a neuropathy can be diabetes, okay, flow of blood towards the area of, now when we speak in peripheral nerves, a lot of times it occurs in the hands and in the feet. So we know that diabetes could be a cause of peripheral neuropathy due to blood flow towards the areas of the feet. Chemotherapy, okay, alcoholism, poor nutrition or vitamin deficiency. So we also know that when you don't have B12, for example, the brain, people can be suffering from pain. A lot of times, okay, you have a B12 in deficiency, here, take B12, okay? And then suddenly this pain disappears. It could be what I mean by poor nutrition or vitamins. They eat all day bread, for example, okay? And they not having a good diet, they might develop pain with time to come, with the time coming, because there are vitamins that are very necessary for nerves to act and respond in the correct manner. Okay, you have kidney or thyroid diseases, herniated disc. That's what I'm saying. When the herniated disc might be pressure, okay, due to a prolapse disc on the area of the nerve, which is causing damage to the nerve itself, okay, and it's got no connection on halfway through. Let's say it's not on the nociceptors, but actually pressure some way throughout the nerve root, and that's also causing a signal of pain. Again, think about it, the idea that there's pressure. Again, I'm misinterpreting the information that is coming there. So that's why I herniated this. Okay, medicine, okay, can also occur the pain, and autoimmune diseases can also cause neuropathy. Okay, when you come to speak about CIPN, which is chemotherapy-induced peripheral neuropathy, a lot of times when it comes to speaking about chemotherapy, the pain can occur immediately. Okay, they can be taking 2, 3, 4 sessions of chemotherapy, and suddenly on the 5th chemotherapy, they start receiving this pain. Okay, so what is happening? The chemotherapy is killing out all these nerves. It's not only killing out the cancer and the tumor, it's also causing damage throughout the nerve. So again, the nerve is being damaged. But with chemotherapy, the patient knows exactly when it started. Okay, so a lot of times when you know exactly when it started, they refer themselves to the oncologist, and the oncologist might change the type of chemotherapy in which the patients receive. And in many cases, once it's changed, the neuropathy disappears. But what is the cause of patients that are receiving chemotherapy and the neuropathy, they know exactly when it started, exactly how it started, and it's very, very specific. And it's easy to control it. Okay? If it's not controlled, it's going to develop to a chronic state. Now, what is important, remember, a nerve and it's in those cases very easy to treat. Now, also you have a 10-year window. What do I mean a 10-year window? You have 10 years after post chemotherapy, the nerves can still degenerate, and slowly, this neuropathy, the peripheral neuropathy that they're suffering from, will be lessen and lessen and lessen, and even improved their quality of life will improve. After 10 years, it's very, very difficult to treat it. And how can you treat it? First of all, I like to, acupuncture is very, very useful in treating it. Physiotherapy is also very useful. Or occupational therapy is very, very useful. What do you mean? Remember, you want to stimulate the area that's been sending out this bad signal, especially in the hands or in the feet. And if you send out this new sensory stimuli, new sensory information, in the end, it's like clearing off, making the picture, going over the maps and start strengthening the lines. And then this map becomes more and more, less and less blurry. And you can see it in a lot better. It's like renovating this map. Okay. For example, if a patient suffering from balance disorders, then ask it to walk backwards and forwards or stand on a bubble of foam. Okay, if he's having a neuropathy in his hand, you can put the hand in the treatment of a lot of seeds and beans, and it actually also calms down the neuropathy of the pins and needles that they feel in the hand. Okay, if the drugs can be used, for example, there are different types of meds that they can take that will drop the neuropathy. But also, if we're speaking about vitamins, you can give vitamin B, complex B, vitamin C, glutathione, which is an antioxidant, okay, L-carnitine, alpha folic acid. So you're actually giving all these nutrients that might help the nerve regenerate itself, and these antioxidants, which will help the nerve regenerate itself and actually then heal it. So coming now we've kind of touched base. What is neuropathy? Of course, it's on the edge of the fork, I say. We have a saying in Hebrew, al ktsei hamazleg, which means on the edge of the fork. It's like on the tip of the tongue. It's very, very general because our topic is YNSA. And I always like to start when I speak about YNSA to speak about this sentence that Yamamoto speaks about, which if you don't give up at the library, paralysis and pain will heal. And basically what he's saying that the nerve system, central nervous system, and the peripheral nerve system can regenerate. And if you keep stimulating it again and again and again, in the end, the body has can heal itself, and then it'll overlap and manage to overlap the area that's damaged. That's what it's trying to say. Or in some words, it's saying like, this is neuroplastic. This is the neuroplastic pain. Okay, the brain has an ability to regenerate itself and recreate itself. And if you keep recreating itself, it's going to overlap the areas of damage and start functioning in the correct manner. Okay, so Dr. Toshikatsu Yamamoto, in the end of April, actually, he's the founder of the YNSA method. He actually decided to retire at the end of last April from clinical practice. His life work has been about 50 years just developing and working with this YNSA system. He has a hospital where this system is being used, rehabilitation clinic where his system is being used. He also has an old age home where this system is being used. Today he's around 90 years old. He started out as an anesthesiologist, and throughout his life as an anesthesiologist, he found himself when he was trying to manage pain, he found himself going into using acupuncture. From acupuncture, started practicing Chinese scalp acupuncture. From Chinese scalp acupuncture, that is where he discovered the YNSA. So, just for a quick idea, Yamamoto was always looking for new ways to manage pain on his patients. Now, a lot of us are familiar with the Chinese scalp acupuncture. The Chinese scalp acupuncture is is based on the neuroanatomy of the brain and the homunculus. So we have areas that are motor lines, sorry that my lines skew, and sensory lines, for example. Okay, motor and sensory lines. Then we have the areas of speech. Also here there's an area of speech. We have the area of the optic region, balance regions. But what is in this Chinese scalp acupuncture? The areas that are needled are actually matching the neuroanatomy of the brain. Understand it? So for example, if you have an area of pain in the shoulder, you want to look where the area on the scalp is of the homunculus on the scalp is located and needle that area, thread through that area, and then you're going to treat the pain on the shoulder. What happened that one day a patient walked into Yamamoto's clinic and he was suffering from sensitivity in the area of the shoulder, okay, and pain in the shoulder. And when Yamamoto was actually trying to search where the area of the shoulder was in Chinese scalp acupuncture, he found sensitive area around here, around the shoulder. And by pressing down on that area, actually suddenly the patient felt that the area of his shoulder, the pain subsided. And then Yamamoto said, okay, this is interesting. Most probably said this is interesting. And then he started Yamamoto likes to think out of the box. Said, okay, if I have an area of shoulder here, and he started practicing it on other patients, and he was starting to get a very good result. So he said, okay, this is the area of the shoulder, which will be the C point, which we'll know into the future, the C basic point. And he actually connected between, we have the Chinese scalp acupuncture here, which you have the area of the head, and he starts saying, if I have the head here, the shoulder here, then right throughout I might have the whole body throughout this hairline. And then this is his microsystem, which Yamamoto developed, where YNSA is more of a microsystem than based on the homunculus of the brain. Now, because everything he looks as a mirror reflection, he was saying if I have a mirror reflection on the inside and the area, yin aspect, okay, it's an anterior aspect. It's not yin and yang theory, an anterior aspect. And if the points here don't work, let me look on the posterior area of the scalp. There's a mirror reflect. And the posterior area of the scalp actually is accumulated on the lamoid suture, lamoid occipital suture. Okay? And on the inside, it's right on the hairline. YNSA method is being developed for 50 years, and today, if it started from only basic points, it moves. There's a couple of groups of points. We have basic points, we have sensory points and brain points. We have epsilon, which are the organs and the channels. We have cranial nerves, and we have all these extra somatotopes that are very, very effective in treating patients. So some of these, to make it more understandable or more practical, this lecture, I'll speak about some of these points so you can use them already in the clinic with these patients that are suffering from this peripheral neuropathy. Now, the understanding, when you come in to treat the neuropathy, what you want to do, it's very, very simple, because you have this very kind of complex disease, but the treatment is very simple. And I always found that given a very simple treatment has a maximum effect on a very complicated disease. And this is a YNSA system is an amazing system which you can work with. So it's very, very simple. And again, what you want to do is kind of remap or draw the map or make that map that's been damaged more visible or less blurry. And if you get a less blurry, you can treat the disorder. So I like these are these great 4 points, these tinnitus points. It's actually a tinnitus combination. These points are actually originated and being used for treating tinnitus. Okay. Now, with my experience with YNSA, Yamamoto is a developer of the system, but I always have my spice in it. From my experience in clinical practice, I actually found that certain points might be very effective in treating different disorders. So in this disorder, the tinnitus actually is very, very useful in treating balance disorders or numbness in neuropathy. Okay? For example, if I'm having numbness on my area of my left foot, I'll needle these points on the left side, the ipsilateral needle. And they're very, very simple to locate. What do I mean? Okay, so there's 4 points. So I like to say the ear-yang point, what you see here, ear-yang is actually gallbladder 19 point. Okay, now we know gallbladder 19 sits right by the cerebellum, so it's got to do with balance. Okay, and then we have the ear-yin point. The ear-yin point, if we would divide the forehead into thirds. Sorry, let me go to my. Okay, if I would take the forehead and divide it into thirds, okay, I go to the lower border, and here we have our hairline, okay? I go to the lower border of the upper third, okay? And the lower border, upper third of the forehead, and I go continue from the temporalis muscle to that. If I'm just superior to the temporalis muscle, I imagine a line going down from the temporalis muscle towards the nasal bridge. And when I hitch that upper third, I look for a bump. And that bump is the ear yin point. Okay? Then we have 2 points that are located in between. So these, first I have my apex line. My apex line runs from my apex up to do 20. Okay? Up to do 20. And then I take my ear and I multiply my height of my ear, which will put me right up here. And then I go 2 to 3 centimeters anterior and look for a big divot in the temporalis fascia, which will put me in tinnitus 2, or 3 to 4 centimeters posterior, which will put me into tinnitus 1. But we'll have an image in a minute to show it better. So that's one point which is very, very good for numbness and balance disorders due to neuropathy. Next, we have Isomotiv. Isomotiv is also very, very useful in neuropathy. What we want to know is where, again, what is important is the foot and the hand area. Okay, so we have the apex line. Okay, all of the mastoid process is going to imitate, as this image is, as is it. So all the mastoid process is going to be the lumbar spine. If you go up with your lumbar spine, with the mastoid process, you're going to feel a divot on the posterior area. That divot is the area of the hip. And then from that hip, you can go directly up 90 degrees. And again, you multiply the height of the ear. And the area after you've multiplied the height of the ear, that's the area of the foot. Okay, which is very, very important in that case. So that's the anterior. That's area for the foot. The hand, okay, again, if we go to the root of the ear, okay, so we go the right to the root of the ear, and from the root of the ear, we go about, again, multiply the height of the ear, go to the superior borders of the temporalis, and 90 degrees nearly up, you'll find the area of the hand, okay? So it's a bit posterior to stomach 8. So you have stomach 8 here, so you go a bit posterior to stomach 8. That is where the area of the hand. So again, when you have neuropathy, anytime pins of needles in the hands, could be pain in the hands, could be heat or cold in the hands, also in the foot. So these areas are very, very useful in needling for neuropathy of those areas. Oh, sorry, I don't know why this image is here, but sorry. This is another, just explain it if it's here. These are another points that can be used actually to treat general areas of the body. So we have the lumbar spine, thoracic spine, and cervical spine. Where these 2 points are located, you have A point. A point is a point that treats the head down to cervical 1, cervical 7. Okay, A point is a 2 centimeter vertical line that starts from 1 centimeter into the hairline to 1 centimeter below the hairline. Okay, it's approximately 1 centimeter. Okay, so in a different way of saying soon. If you can see here, it's actually on the line of the bladder channel. Okay, so bladder 3, from bladder 3, you go 1 centimeter up or 1 centimeter down. That's going to be the A point. The upper part's going to be the head, the lower part's going to be cervical 7. Then we have E area, E point, which treats the thoracic spine. So it starts from the area actually of gallbladder. It's actually located in the supraciliary ridge. Okay, and it starts from 1 centimeter above the eyebrow lateral and goes from one inward to 1 centimeter inner medial to the eyebrow. It's around, if you have bladder 2, so just above bladder 2. Okay, and these points are actually located in between the two in equal divisions. So the medial part of these points are in equal divisions from the inferior part of A to the medial part of E. So you have lumbar spine, thoracic spine, cervical spine. So first of all, you needle the medial points if you're having a disorder, again, ipsilateral. Again, if they don't assist, then you go to the lateral points. And as you can see, the lateral points are lateral to these lines, and they in between the gaps that will be accumulated from the equal division between 1, 2, and 3. Okay, and they also sensory points. So here we'll draw out the image on about these points that we spoke about right now. So first of all, we need our hairline. Okay, I'm going to start with those with Isomotiv. So if we have our mastoid process here, okay. So if we go to our mastoid process, and you can see here we have that divot, that gap. Okay, that's going to be the area of the hip. And then you go 1 centimeter, about multiply the area of the foot upwards. Okay, I'm taking the ear, I'm multiplying height, it'll get me about here. It's going to be the area of the foot. So that's going to be the eye of the foot. The area of the hand, if we have the root of the ear here, which is actually the shoulder region, and then again 1 centimeter up, not 1 centimeter up, 90 degrees up in a direct line will give me the area of the hands. Okay, that's going to be the area of the hand. So that's the eye somototo. Now to that area of the tinnitus. So first of all, I'm just going to draw the apex. So we have this line, which is the apex. Okay, the apex line. It's actually the coronary line. Now remember, I said you divide, here we have the temporalis muscle. That's the temporalis muscle. So like I said, if you continue above the temporalis muscle to the upper third, you're going to get to a bump around here. That's the ear yin point. That's ear yin. Now, tinnitus gallbladder 19 is about here, so that's the ear yang. And then you have 2 points in between. So you have the apex line, you go 2 to 3 centimeters anterior. You'll find a point here. And 3 to 4 centimeters posterior, about here, you'll find another divot there. So that's also very, very good for tinnitus, for balance. And also tinnitus and any types of disorders of the ear. Next, we go to those 3 points which we spoke about here. So we need this is our hairline. Okay, this is the mid-sagittal line. Okay, now I need A point. So I said A point is about bladder 2, bladder 3, 1 centimeter above, 1 centimeter below. E in the superciliary ridge, which is down here. Okay, and then we have in equal divisions, we have, you can see that'll be lumbar, thoracic, and cervical. Okay, in equal divisions. And then the outer one will be, again, in between. So we have lumbar, thoracic, and cervical. Basically, if you're familiar with the YNSA system, the sensory points go right in between here. That's where the sensory points are located. So that's these points. And again, if you think about it, next points that I found that are also very, very, very useful in peripheral neuropathy are the areas actually on the ankle. Now, not necessarily they only treat the area of the ankle, but they'll treat throughout the body. And they're very, very useful. So they're just below the malleolus. So if we look just below the malleolus, on the malleolus, the tip of the malleolus, okay? Now the difference between the anterior, the medial area and the lateral, that the lateral part is going to treat the posterior parts of the body. Okay, so it's more here, what you see here, a brain, it's more the posterior brain. Okay, the medial part is going to treat the anterior part of the body. Okay, anterior part. Okay, you have here UB, which is upper body, MB is medial body, and lower body. So upper body is neck, upper extremities, and head. Medial part is the thoracic spine to the area of the lumbar spine, and then Lower body is actually from the lower lumbar spine down to area of the feet. Okay, and they very, very useful in treating neuropathy in those areas. So again, the tip of the malleolus is going to be the area of the brain. Okay, and then the upper malleolus, upper body, what we see here, upper body is just, if we take our malleolus, just below the malleolus. Okay, that's the upper body. The lower body is between the calcaneus and the plantar fascia, and the medial body is in between the two. The same idea, you can see it goes here. If we look at the malleolus right here, you can see the upper body is just below the malleolus, the center of the malleolus in 90 degrees. And then you have the plantar fascia and the calcaneus, so you have the lower body, and the medial body is right in between the two. And that's very, very useful for treating throughout the whole body itself. Then we come into 2 points that are very, very useful for neuropathia in the hands, in the area of the hands. So again, that pins and needles, that numbness, that pain or heat, cold, that are area of the hands. Now the difference is you have, again, lateral and medial. Lateral and medial. This is called soleus points. Now the lateral area is going to treat the dorsal area of the hand, and the medial area is going to treat the medial area of the hand. That's the difference between the two. Okay? Now, the area of the lateral is actually where the soleus integrates to the Achilles tendon, and you needle deeply here. What you're going to do, you're going to look for a sensitive area. When you palpate, it's around bladder 59, UB 59 on the lateral area. You're going to palpate around and look for a sensitive point, and then needle that. At the same time, when you put pressure, you can ask the patient if it feels better in the hand. If he says yes, that's where you needle. And the area of the medial is around bladder 50, around kidney 7 and 8 area. Again, that's where you want to press, see if he has improvement in his plantar hand. If he has improvement in the plantar hand, that's the area which you needle. Okay, so basically what it's kind of on the edge of the tip here, what I showed you and taught you, but these points are very, very useful in treating these neuropathy. These are the points, or the main points that I use when I'm treating neuropathy, especially chemotherapy-induced neuropathy. I do recommend to use them. Hopefully you guys will find them very, very useful in your clinic, even tomorrow, the next day, if any patients come in to you. Thank you very much for listening to me. I do not take it for granted that people come to listen to my lectures. I like to say, for all my students, I learned the most, and thank you for that. Thank you for, even for me teaching, or if you have your questions, I learn a lot from it. It makes me deepen my knowledge into the system. Here's again my contact information, our contact information. Feel free to go to there, email me. Thank you very much. Again, thank you very much to the organizers of this conference for inviting me to speak. I know this was a very, very short lecture. Usually these topics you can go in for hours about, even give full work. I give full workshops on them. So it's kind of the tip of the fork, I like to say, but I hope they're very, very useful, and you found these images very, very useful for you and these explanations. If not, I have a lot of information on my YouTube page, so you can go there as well and see these videos for free. Thank you very much, all of you. Again, keep well.